utilizes an experimental medicine approach that we know well here at SOBC to identify cognitive affective mechanisms that contribute to health behaviors and physical disease. Also, isolate how these mechanisms influence health behaviors in real time using both laboratory methodologies and others, and in turn develop tailored interventions that target these mechanisms to promote health behavior change and prevent the onset or progression of chronic disease. Dr. Ferris is also a licensed clinical psychologist in the state of New Jersey, New York, and Rhode Island, and specializes in cognitive behavioral therapy for the treatment of anxiety and related disorders. Clearly, she doesn't sleep a lot, but we're very, very thrilled to have her here. Dr. Ferris, I'll turn it over to you.
Thank you, Dr. Edmondson. Can we still see my screen? Just want to confirm. Excellent. Well, thanks for that lovely introduction. And say the feeling is mutual. I've been very excited to have this talk bookmarked on my calendar. So, the work that my lab is doing at Rutgers, not far at all from where you guys are at Columbia. So very excited to be able to present today. And, the topic that I'll be focused on today is one specific line of my research that's focused on understanding fear and avoidance related to exercise. And I'll be talking about that in the context today of cardiac rehabilitation. I have no disclosures to report other than funding from NIH and from Rutgers. And just briefly for my plan today, I want to introduce briefly what cardiac rehab is, since that'll be a focus of the talk today. And then I'll introduce my conceptualization of exercise and fear avoidance mechanisms related to that. And I'll define for you and talk about some of the measurement development work we've been doing related to the construct of exercise sensitivity. And then I'll talk about the development of a novel intervention that's focused on targeting exercise sensitivity. So that's the plan for today, and I'll kind of move us through. And what I've tried to do is integrate not only some research, but also some clinical examples to really highlight the way I look at my research as a scientist practitioner, and also try to bring to life some of the research with some patient quotes and some illustrative examples. So hopefully we'll get a nice dose of both clinical application, but also the research. So let's start with cardiac rehab. And just very briefly, so we're all on the same page, cardiac rehab is a comprehensive secondary prevention program that's a standardized part of secondary prevention for patients with cardiac rehab. And the primary goals of cardiac rehab are to improve functional capacity, speed recovery from cardiac events or surgical procedures, also manage risk factors that might contribute to early morbidity and mortality, and also to promote physical activity and healthy lifestyles in the context of cardiovascular disease. And just for context, cardiac rehab is fairly intensive. Usually insurance will cover up to 36 sessions. Sessions are multiple times a week, 2 to 3 times, and the session length can vary anywhere from 1 to 2 hours per session. And what's important to note is that cardiac rehab is multi-component. So it involves, in addition to medical evaluation, exercise or cardiovascular conditioning, and then counseling and risk factor management. My interest is really in the exercise part of cardiac rehab because I really view cardiac rehab as this window of opportunity for patients who might otherwise be physically inactive to start adopting a new exercise routine and really a more healthy lifestyle routine. And so one of the reasons why I really like cardiac rehab for exercise promotion, especially for older adults who may be very deconditioned, not otherwise involved in exercise, is that cardiac rehab has structured and supervised exercise that also includes ECG monitoring based on patients' risk factors. And the supervision is important so that patients can feel like they're getting, safe exercise training and a higher level of tailored intervention based on what their needs are. And exercise can include both cardiovascular conditioning, resistance training, and then relaxation and stretching. And what's also really nice is that in addition to structured bouts of exercise that cardiac rehab sessions provide, there's also an opportunity, if the intervention is tailored right, to also start promoting and encouraging regular lifestyle activity routines outside of the clinic. So when patients are at home, we want them to still be exercising and not just maintaining sedentary lifestyles and being active only when they come to the clinic. So, it's really this window of opportunity to promote whole new uptake of exercise, but also more active lifestyle on a daily basis. However, despite the efficacy and the benefits of cardiac rehab, there's very low uptake. So I'm only focused here on patients who enroll, and of those who enroll, the majority only attend a portion of the sessions. Now, this is a problem because exercise, as many of us know, is dose dependent. So the more you do, the better benefit you'll have. Also, even among those who do attend cardiac rehab, the majority don't maintain a healthy lifestyle or this kind of physically active lifestyle after cardiac rehab. And these are in, prospective follow-up studies that monitor patients up to a year later, and they find that, cardiac rehab alone doesn't necessarily predict uptake of physical activity on a lifestyle level. And what's also concerning is that adherence to cardiac rehab is expected to further decline in the future as our population continues to age, given that older age is one of the most consistent predictors of non-adherence to cardiac rehab. So my interest as a clinical psychologist focused on anxiety and fear is, understanding to what extent might low adherence to cardiac rehab and related exercise be related to anxiety. And so let's jump into that. What I'll do is introduce the focus of exercise, fear, and avoidance in cardiac rehab, and I'll show you some examples of some of the work we've done in the lab and also in the clinic that highlight our work in this area. So if we think about, why patients might be fearful of exercise, well, many of them are deconditioned. They're, not used to exercising. They have physical comorbidities that might make exercise very uncomfortable. And also for a lot of the patients coming into cardiac rehab, they, have recently or in the recent, past 3 months or so have experienced some sort of major cardiac event or have undergone a surgical procedure or some other procedure that is, that can produce a lot of somatic dysfunction and can make patients quite hypervigilant to what's going on in their bodies. And it's possible that during exercise, a lot of the sensations that these patients are fearful of, or I should say, can produce fear of these sensations because many of these exercise sensations can overlap with the symptoms that these patients experience as a consequence of their cardiovascular condition or health. So what we did in a very basic study was we asked patients some close-ended consequences here about exercise. We said, so, to what extent are you worried about the following consequences during exercise? And our patients told us that on average, or these are percentages of our sample, I believe we had about 69 patients in this study. So, a good proportion of them were worried about a few specific things. So not being able to breathe during exercise, concerns about having a cardiac event, concern that something, kind of diffuse uncertainty, something might happen. And then a good proportion also told us that stopping or slowing down during exercise in response to bodily sensations was something that they commonly engaged in. And then we also asked, if people thought it would be beneficial to address exercise fears in cardiac rehab, and the majority told us that they did. And so to some extent, we can understand that it would be concerning, it would be fearful for these patients to exercise, if they haven't done so before. Moving this out of my way. And also, because of the kind of noise, the dysfunction in their bodies that result from their acute conditions can really heighten their awareness to these bodily sensations. And that awareness can also lead to worry about the meaning of those sensations. So if we think about this construct of interoceptive sensitivity, what this really means is a general fear of kind of the noise in your body. I was talking to my friend the other day. I'll give this example that he was raising, which was, he's telling me about how he had this kind of soreness in his throat and a little bit of a headache. And, he was very aware of these sensations and starting to be very fearful because he started to worry, well, is this COVID? Am I getting sick? Do I have some sort of viral infection? Now, if there wasn't a global pandemic, he may not be focused on those sensations or fearful of them. On any given time, having a sore throat or having a headache, you might think, not feeling great today. You might not even think anything of it. But salient events that happen either at the level of the person or, societally, anything that could be potentially threatening to an individual can certainly increase kind of awareness and attention to what's going on in our bodies. And this is a problem if patients are very actively aware of what's going on in their bodies, because our bodies are noisy. There's always kind of something going on internally, and the extent to that we're very focused on it and then fearfully respond to it could be a driving factor during exercise. So the extent to which exercise sensations are eliciting concern and fear could be a barrier for patients engaging in cardiac rehab. So we've done a few different studies. I'll highlight what we've done in the lab. This is just a picture of my exercise lab at Rutgers. And we've done a few studies where we've found that interoceptive sensitivity, this kind of fear of what's going on in the body, is related to various aspects of exercise. And these studies were not in patients with cardiovascular disease, but those who are at high risk for cardiovascular disease. So those with obesity, low activity, low physical activity, and also cigarette smokers. And here we found that heightened interoceptive sensitivity is associated with lower enjoyment of exercise and also lower exercise tolerance. And what we've also found is that right before doing a submaximal exercise test in the lab, we found that those with higher interoceptive sensitivity report more anxiety right before and lower mood right before doing the exercise test. During the exercise test, they experience greater exertion. So their subjective experience of exercise, especially as exercise becomes more prolonged, is perceived as more difficult and challenging. And I'll note that physiologically, when we look at other kind of signals like heart rate, we don't see any differences. So this really is a subjective appraisal of the exercise experience. And interestingly, after exercise, those who have elevated interoceptive sensitivity actually experience an anxiogenic response, so increased anxiety as a result of exercise, where, typically or on average, we actually see an anxiolytic response, that people feel less anxious after a bout of exercise. And so what this tells us collectively, and my work's not the only to focus on this, but in these individuals who are at high risk for cardiovascular disease, who have different health comorbidities, if they're very vigilant and fearful about internal bodily sensations, exercise doesn't feel the same for them, and there's this subjective kind of distress response. In a study that we did in patients attending cardiac rehab, we also found that interoceptive sensitivity was correlated, and this is cross-sectionally, with more fear of exercise. And this is in patients in cardiac rehab. And we found this to be true even after adjusting for factors that might be related to both interoceptive sensitivity and exercise fears. So there's a signal here that definitely points to the fact that this kind of sensitivity to bodily sensations might be driving fears about exercise in this group of individuals. So let's talk about measurement, because this has been a real important focus of my research. And I know something that I've talked with some of the folks at the center about is, when I've measured interoceptive sensitivity in the prior studies I just mentioned, we've used the scale called the ASI-3, the Anxiety Sensitivity Index. And this is commonly used in a lot of the literature because it taps sensitivity to sensitivity or fear to anxiety-related sensations. So not specifically anxiety sensations, not bodily sensations more broadly. So let's look at a few examples. So just pulled a few items out of the measure just to focus on for a moment. So it scares me when I blush in front of other people. So blushing is a common symptom of anxiety. So this measure taps into the extent to which individuals are fearful of blushing. Another example, when I feel spacey or spaced out, another kind of cognitive symptom of anxiety, I worry that I may be mentally ill. So this measure, although we see a signal in our data that anxiety sensitivity or kind of fear of anxiety relevant sensations is predictive of exercise experiences and related to exercise fears, the extent to which we're really tapping the construct that we want to, this fear of exercise sensations, may not really be well matched with this measure. Another concern that I had with this measure is that I pulled another two items and I bolded the part of this that I think could be problematic for individuals when responding to items. So what ends up happening here is these items are written such that there's a sensation when my throat feels tight, and then an implied consequence. So I worry that I could choke to death. Or when I feel pain in my chest, I worry that I'm going to have a heart attack. Now, these are common fears that individuals with panic disorder might endorse, or other anxiety disorders, and those that patients with cardiovascular disease or those in cardiac rehab or other health conditions could indeed endorse. However, what we ended up finding, and I'll show you some of this data in a moment, is that a lot of our patients, while they might experience these sensations of throat feeling tight, they don't necessarily worry about this consequence. They might have a different consequence. And so my goal was to figure out if there was a way that we could develop a measure that would be open-ended, so that we're really tapping fear about the sensation without implying a consequence, so that we're really keeping it open-ended for the respondent. And also to include sensations that are relevant to exercise and not those that are specifically or exclusively indicative of anxiety. So while the ASI is definitely, can overlap with sensations of exercise, exercise sensations, exercise sensitivity, as we've kind of defined it, is conceptually distinct. I just want to point out three other measures that have also been published that are sometimes used to tap into exercise fears in this patient population. And I want to just make sure that we can distinguish how they're different from what we're discussing here. So kinesiophobia is probably the most commonly used term in the literature for exercise fears or exercise avoidance. And this term really grew out of the pain literature, and the original TSK, Tampa Scale for Kinesiophobia, was a measure that was developed in pain populations. And so it has been adapted for use in patients with heart disease, but this is really tapping fear related to pain. So the concern that pain might present due to movement or activity. And so pain is one sensation that can come up during exercise, but is very limited in scope. I like some of these acronyms here. The FACS heart failure measure is a measure that's been developed that specifically taps fear and affective responses to different types of situations or activities that are that involve physical activity. Again, this measure is very focused on the cognitions and the emotional responses, but is not focused on the internal physical response, which is what we've been speaking about. And then finally, the FACT-CAD, the fear of activity in patients scale, is one that was recently developed to evaluate beliefs and patients' abilities or attitudes towards different activities. And these aren't specifically aerobic exercise, but different lifestyle activities that are participated in. And this measure is really focused on how people feel as the result or following a cardiac diagnosis. And again, so not quite what we're interested in tapping here with interoception, but nevertheless, these are potentially useful constructs for those who might be interested in this general domain. And so what I'll present now is some work that we've been doing recently on exercise sensitivity and trying to develop better tools to measure this construct. And so we recently published this measure, the Exercise Sensitivity Questionnaire, which I'll refer to as the ESQ from here on out. So this is a measure that we developed to address the issue of the use of the ASI-3 and some of these other limitations of the existing measures that I just walked through. I'm kind of giving you the final result here, but I'll walk through the process of how we got to these items. But we did result in a measure that had 18 items with 2 different factors. And the goal here was to develop a measure that's exercise specific, that doesn't force the consequence, it just is focused on the sensation, and that it is specific to the interoceptive sensations of exercise and not limited to, for example, sensations of anxiety. So what we did is we started with an item pool bank of 55 items that we adapted from Norton and Spears. And we first just asked 16 patients who were in cardiac rehab to answer each item to endorse whether or not, or to give us a kind of a rating of severity. And then also, if you kind of turn your head to the side, you could try to read these here. We asked them to check off when they would be concerned about these symptoms. So it scares me when I have an earache. When would that be concerning to them? In general, only when I exercise, or both, in general and triggered by exercise. And then we asked them to just open-ended, if they endorsed it, tell us a little bit about why that would be potentially concerning to them. And so we had patients do this for all 55 items. And what we did to help with our item reduction is to identify any symptoms that were endorsed by 1 or more patients of being relevant to exercise, or both being in general a concern and also triggered by exercise. Those were then retained and used for our psychometric evaluation. So for the psychometric portion of the study, we had two different samples. One was a community sample that we recruited online of patients, or I should say community members, with either qualifying condition for cardiac rehab via self-report or 2 risk factors for cardiovascular disease. And then our second sample, we had 50 patients who were attending outpatient cardiac rehab. And so I mentioned that we had 18 items, and so 2 factors were identified from our exploratory factor analysis and very nicely split into 9 items on each. And the first factor we captured and kind of described as being fear due to cardiopulmonary sensations. And so on the left here, I'll show you the item, and I bolded the sensation just to make it easier to see, and then just to highlight some of the patient responses, just to give you a sense of the fears that these patients have. I provided some of their open-ended qualitative responses as well. So for instance, I would worry if my vision was blurry, and I didn't include this in here, but you should know that after each sensation, we have the text added during exercise. So for all of these, they should be read, I would worry if my vision was blurry during exercise. And so then they could write in why this would be a concern to them. I'll just have each of the different sensations come up, and you just pause for a moment so you can read along. And then 9 different sensations that loaded onto a factor that we characterized as fear of pain and weakness sensations. And I'll show you as well. And one thing I'll just point out that really struck us as we were doing this work, and I think is important to specifically highlight, is that a lot of the concerns that patients had, albeit sometimes were some catastrophic outcome, like, you know, am I having another heart attack? Often it was characterized by uncertainty. So, you know, concerns like, I worry about the cause of this. If my lower back was hurting, or if my body was aching, you know, why would that be? And I think that's really important, because it's not always that there's a catastrophic belief that patients have if they experience sensations during exercise. What they're telling us, and what the data show here, is that, you know, oftentimes it's either just very uncomfortable, as illustrated by you know, this one here, it hurts. Can I do this? It hurts. So that's just low tolerance for the distress. In other cases, uncertainty, like worrying about the cause, is something that, you know, by having an open-ended, not a forced consequence, it allows for patients to respond simply to the sensation if it's something that is a feared sensation to them for during exercise. Continuing with our psychometric work on this measure, we found that the ESQ items were cross-sectionally correlated with other indices that we would expect it to, like cardiac anxiety, discomfort and tolerance, depression, and generalized worry. And what we also found was that the measure items were predictive of physical activity engagement. So in our first set of prediction, we used self-reported physical activity participation, and we found that higher exercise sensitivity scores Those who had high scores were significantly less likely to engage in any moderate to vigorous physical activity in the past 7 days compared to those with low exercise sensitivity scores. And then prospectively, in a cohort of our patients enrolled in cardiac rehab, we had them wear a polar actigraph watch for 7 days. And we found that, although this was a small sample of patients, we found that ESQ scores were negatively correlated with physical activity levels. So we're having a signal here, at least in this initial study, that the ESQ is associated with lower physical activity participation. So as part of my work in this area, what we then did was leverage this measure of exercise sensitivity and the prior work that we had done, really identifying this as a target mechanism, to develop an intervention where we could actually try to modify or reduce exercise sensitivity in patients in cardiac rehab to try to see if that could increase their exercise participation and lifestyle physical activity. And this was a project that I received pilot funding from Rutgers University through an internal grant mechanism. And so I'll present today kind of the overview of the BFIT intervention, and then I'll also present some very hot off the presses outcome data. We're still in the process of writing this up, but I wanted to include it because it's you know, the direction of where this research is going. So just keep in mind, it's a very small sample of patients that we recruited for the pilot study. So we had 12 patients who were on average 72 years old, and majority were male. And I'll walk through what exactly the intervention was. I'll give you some clinical examples of what we learned from our patients. But in brief, the intervention is entitled BFIT, which stands for Behavioral Exposure for Interoceptive Tolerance. So, you know, I've explained already that interoceptive sensitivity, this tendency to be very fearful of exercise sensations, is you know, this potential barrier to exercise. And so if we can build tolerance to internal sensations, interoceptive sensations, that could be this mechanism through which an intervention could promote positive exercise outcomes. And so this was designed as a 6-session cognitive behavioral intervention to be delivered at the beginning of cardiac rehab. So when patients are first starting, they're at greatest risk of dropping out of cardiac rehab. And so we thought, could we add this on as almost like a little mini kind of booster or boot camp to get patients more tolerant of exercise, less fearful of it at the beginning of rehab. So we aim to deliver the 6 sessions twice a week at the first 3 weeks of rehab, at least in the first 4 weeks. So what we did in our pilot study is we, during the standard orientation that patients had for cardiac rehab clinic, where they came in for medical screening and clearance, orientation to the clinic, a tour. We also screened patients for exercise sensitivity concerns. And based on the measurement development work that we did, we used a cutoff score of 30 to indicate elevated anxiety or anxiety about exercise or exercise anxiety. So we screened about, I think about 80 patients over the course of 9 months that we were running our pilot. And we found that roughly 50% of those were eligible on the basis of having an elevated ESQ score and also being low active. Those were our main criterion, in addition to them being at least 40 years of age, which I think there was only one person who did not meet that criteria, if any, and then also being fluent in English. If any persons coming into the clinic had elevated scores, we approached them about the possibility to participate in a brief intervention to reduce fear and anxiety about exercise and to increase lifestyle physical activity. And we gave them a polar activity watch as part of the program as well. So if participants were interested at this stage, we consented them, we taught them how to use the watch, and then we oriented them into the study schedule timeline. And this here kind of depicts what we showed them as well. So we scheduled out their sessions, introduced them to the interventionist that would be working with them, and ensured that on days in which we were going to see them for their BFIT session, that it coincided with one of their pre-existing sessions for cardiac rehab. We would schedule them for either 30 or 45 minutes before or after their normal cardiac rehab session. So we really tried to make this an add-on to what they were already doing. They only came into the clinic on days when they were already scheduled to be there. So they just stayed a little bit longer or came a little bit earlier on days when they were having their BFIT sessions. And so for this brief intervention and for this pilot study, we had 1 week of physical activity monitoring before any intervention started for 7 days to get baseline activity levels. And then patients wore the activity watch the entire time. We did self-report assessments at baseline, mid-treatment at session 3 or after session 3. And then they wore the watch again for 7 days without any intervention at the end of session 6. The BFIT intervention was delivered by either me or I think one of three or four different PhD clinical psychology students who were trained in the intervention and supervised by me during the study. And so the session kind of content is outlined here. Session 1 was really focused on orienting them to the intervention and setting activity goals. We also went over very basic psychoeducation around exercise and what are safe, normal reactions to exercise and what are true warning signs. And then session 2 is where we introduced the idea of exposure as an intervention for building tolerance to interoceptive sensations and decreasing fear. And we also introduced the idea of fading safety behaviors, which I'll talk about in a moment. In the subsequent sessions, we did lots of exercise practice for the purposes of exposures, and we also did other exposure activities as well, again, to build tolerance to exercise sensations, which I'll give you some examples of in a moment. And then session 6 was aimed around relapse prevention and planning ahead for strategies to maintain their lifestyle physical activity. And so I just want to be very clear that in the intervention, we focused on not only increasing exercise participation during cardiac rehab, but also exercise participation at home. So really emphasizing the importance of lifestyle physical activity. So I have a few examples of some of the content of what we learned from patients or what they were shown as part of the intervention. And so in session 1, we review their exercise sensitivity questionnaire and we use it as a clinical tool. So it's not only something that we can use to monitor change in treatment or treatment processes, but we can also use it as a clinical tool to guide the tailoring of the intervention. And so what we do is the clinician would review each sensation and engage the patient in a discussion. If you experience, for instance, difficulty breathing, then why would that be a concern for you? And these are just some of the examples of what we heard from patients during the intervention. It might be something like, well, I wouldn't be able to call for help if I couldn't breathe, right? That's a very different kind of consequence than like I might pass out or I might choke to death, right? So we got very specific concerns from patients if they had it. And if not, and it was just this, I wouldn't be able to tolerate it, it would feel uncomfortable or indicative of just uncertainty, then we really targeted that, right? We might target more of this like decatastrophizing around this, around the sensations, or just building tolerance to uncertainty, that our bodies are noisy and we can't necessarily know what these sensations mean. Then we introduced the cognitive behavioral model of fear and avoidance, and we introduced the role of unhelpful thinking. These are just some screenshots. This is our psychoeducation around real signs to stop exercise and when it's okay to keep going. We also specifically address anxiety related to exercising without supervision. So we encourage them to walk at home. We give them kind of guidance and instruction for how to gauge the intensity of their walking at home, and really you kind of use the saying of like an object in motion stays in motion, an object at rest stays at rest. So the more you do, the more you're likely to keep doing it. And, the goal when you're not at rehab is just to move as much as you can throughout the day. And we really emphasize that the more movement you get, the more that's better for your health, but that's also going to help further build tolerance to the sensations that they're fearful of. We also use the activity watch as an intervention tool. So we use that to monitor their activity levels, their step counts, but we also use it to gauge, their kind of willingness to engage in exercise, or maybe any evidence of avoidance of exercise. So they keep an exercise log as well, and we're able to show them data at each session as some feedback about their activity levels. In session 2, we introduced the rationale for exposure. We really explain it using kind of a case example with a patient here. We kind of tell them about this patient that was enrolled in the program who, had increasing anxiety every time they would walk. And because it felt, intolerable, they would stop, their anxiety went down, and they felt reassured by that. We kind of walked them through this example of, that in the short term, this can be an adaptive strategy, but in the long term, it could actually increase anticipatory anxiety and can promote more avoidance behaviors, and also can get in the way of, valued activities or valued living. So we really try to emphasize, engagement in exercise, for the purposes of living the life that you want to, kind of more of a values-focused rationale, and building tolerance or willingness to experience discomfort in order to meet your valued goals. We also teach them that over time, although their anxiety might decrease, so right, trial 1 of walking, trial 2 of walking, trial 3, trial 4, we walk them through this and show that, the anxiety around the sensations might decrease, but the physical sensations may always be there. And to some extent, that's probably a good thing. It means that you're working hard. And part of our goal is to just decrease that fearful response to the sensations, because we don't want them to interfere with their ability to accomplish their activity goals. Just for the sake of time, I'll continue going through. We also do interoceptive exposures with them in the clinic. supervised by our whoever the interventionist is, also with our exercise physiologist. So for instance, if they had a feared sensation related to difficulty breathing, then we might use straw breathing to specifically elicit that sensation in a controlled way that maybe walking or exercising on a bike might not be able to elicit in the same way. These exposures can be particularly helpful for some sensations that, we're not necessarily going to get at from something like walking, like an unsteady feeling in the legs. We, had one patient kind of bouncing on one leg, the other leg up for 30 seconds, and then try walking. And it kind of simulates this unsteadiness or shakiness in the leg. So we get to be quite creative, lots of kind of supervision and trial and error with the patients to try to simulate sensations that feel as close as possible to the thing that they are fearful of. We do a lot to also identify and fade safety behaviors. So these would be things that the patients are doing that they think are keeping them safe in the clinic or at home on their own, but it actually could be undermining the likelihood that they engage in exercise or just reinforcing that this belief that exercise is unsafe. So patients might stop doing exercise altogether. That's kind of our classic avoidance, but they might be doing other subtle things, and we target this in the intervention. So during rehab, are they slowing down during their exercise training? Are they avoiding exercise sessions when there's no active exercise physiologist near them? Are they kind of gripping onto the machine so tightly that we call it like the death grip on the machine versus like, kind of normally walking or normally interfacing with the machine? I had a patient who would walk and kind of hold onto the wall for kind of this safety thing for balance, even though she didn't have any issues with gait. And very commonly, kind of seeking reassurance, asking the exercise physiologist, am I okay? So we try to monitor these behaviors during rehab, but also point out behaviors that they might be doing on their own at home, avoiding walking too far from the home just in case, keeping medications or a phone nearby them just in case, calling the clinic, messaging their doctor, checking blood pressure, checking heart rate, Googling symptoms, asking family and friend for reassurance, etc. These are just some clinical examples. I had pulled two clinical examples that I thought were a really nice illustration of safety behavior. So one patient said, my heart rate varies a lot. So that's a sensation that she's worried about, variation in her heart rate. So her belief at the beginning of treatment was I needed to check it throughout the day when I'm walking to let me know if it's too high so that I know when to stop. I know what 100 beats per minute feels like. And so we targeted a lot of, not checking heart rate. And another patient said, my doctor said I need to check my blood pressure 2 times a day while sitting and keep a log. I check it 5 to 6 times a day when I feel like my heart is beating. So that's just, kind of whenever he felt like he needed to check it, he would, just to make sure that I'm okay. Sometimes he said he would check it as soon as he got back from back inside after exercising while standing. So he would get these high readings because he was standing up just after exercise, would take his blood pressure. And so, we did a lot of education around how this is not only maintaining anxiety, but is also inconsistent with what the recommended monitoring was. We also do a lot in the clinic. This is just kind of a picture where you can see how where the physician, or in this case, exercise physiologist, is placed during an exercise session might make a big difference in terms of patients' level of anxiety. So we will strategically place ourselves if this is easier for the patient to engage in exercise with a support person there. We might start with that, but make it very clear that, I'm here right now and providing a level of reassurance for you because I'm here. What would it be like if I wasn't here? If I was, 10 feet away, if I was the person sitting at the desk, how would that change your level of anxiety? We also ask them, if you were on a different machine, how would that change it? Are you specifically avoiding any machines in the clinic? And so we try to work with the team and have an exercise physiologist that is specifically trained to work with the patients in a consistent framework with the BFIT intervention to make sure that we're targeting this as consistently as possible across settings. Just a few more examples. We have them log their exposures, monitor feelings of anxiety, breathlessness, exertion, any avoidance behaviors during different exposures. And just preliminary data of our 12 patients, we had no side effects or adverse events in the study. All the patients attended the sessions. They really liked wearing the activity watch, and overall were very satisfied with the intervention. We saw a nice signal for reductions in our exercise sensitivity, the ESQ measure, which are pretty large effects. And we also saw nice reductions in, nice increases in steps per day and moderate to vigorous physical activity per day, again, measured with the watch. And we actually had a comparison cohort. These folks weren't really in the study, but we had 7 patients that just wore the activity watch. And so I just have some, plots here that can show you just patients who wore a watch while starting cardiac rehab compared to those who enrolled in our intervention, and how physical activity changes as a result. And I think this is important comparison data because everyone is engaged in cardiac rehab and they're starting rehab. So you could assume or kind of hypothesize that, well, activity would increase just because they started an intervention. And actually what we found is that, the gray line, at least in this cohort of 7 patients, they really didn't change their activity that much. And this is seen in both steps per day and moderate to vigorous physical activity per day. And the same pattern is true when you look at just rehab days or just non-rehab days. So, this gives us some confidence that, our intervention is doing something here for physical activity above and beyond what cardiac rehab alone would be doing. So that's really nice effects to see, although very preliminary given the small nature of this sample. Next steps, just before I wrap up, and happy to answer questions as well. Our goal would be to be able to do a large-scale efficacy trial to really fully test the efficacy, in addition to the mechanisms of change of BFIT compared to an active control condition. So I have proposed here what we are conceptually proposing and have sought funding from NIA for this study, where we would compare BFIT to a health education control condition and measure exercise anxiety using our ESQ measure, but also triangulating that with other indices, both cognitive, behavioral observation, and physiological indices of anxiety as well, to see if these are mechanisms that are engaged or targeted from our BFIT intervention, and in turn, if those produce changes in cardiac rehab adherence and also lifestyle physical activity adherence. And this is just a schematic of what the intervention would look like. Very similar structure. The main difference being that patients would be actively randomized to one of the 2 conditions, health education control or BFIT. And then our end of treatment assessment would occur at week 6, but then we would add 3 follow-up appointments to really look at the durability of these intervention effects as well. Fingers crossed that we can get funding for that. And I'll wrap it up there, and happy to answer questions. I feel like I could talk about this all day, so please do feel free to reach out to me if you have questions, or if you're interested in hearing more. Thank you.
Dr. Ferris, just outstanding. It's just such a cool program of research and a really impressive presentation. This program, BFIT, this is my first time seeing it. And I'm just bowled over. I know I speak for Dr. Ian Cronish, who is the PI of the Columbia Roybal Center for Fearless Behavior Change, that we're very disappointed that our Roybal Center wasn't around early enough to get to invest in this great program, because it's so consistent with what's going on there.
Thanks.
So no one has beat me to the Q&A yet, it looks like, although maybe I'm seeing a chat here. Actually, Ian Cronish has something here. Did you review content of cardiac rehab to see if any content in sort of normal cardiac rehab either undermined or contradicted BFIT?
Yeah, this is a tricky, it's a tricky question. We did not do any systematic review of this, but what we've done to address this issue, because there are, I don't know if contraindication, that sounds a little too strong of a term, but there are definitely inconsistencies with what, for instance, standard monitoring standard monitoring protocols in exercise physiology might propose versus what we might ideally want from our exercise physiologists. So for instance, we might not want to continually provide patients with reassurance about their heart rate, or about blood pressure, or about other vital signs that are being checked during rehab or during exercise, because that could become this set of feedback that patients feel like they need to get in order to ensure or to confirm that they're okay. So the implication then being, if they're not getting that feedback, then they might not be okay. And that really narrows the circumstances in which they might feel comfortable exercising. So to address this issue, what we've done is just worked directly with an exercise physiologist and cardiac nurse and cardiologist to make sure that they are on board and understand the rationale for the intervention. And then we try our best to make sure that during rehab, the patients aren't getting conflicting information. Oh, thanks, Lisa. I see her comment come up there. But it is something that it's almost a separate, I think Ian and I have talked about briefly, a separate question, because, and an important one that I think really warrants studying, because the protocols of cardiac rehab were designed for medical safety, right? And they weren't necessarily at all designed for promoting psychological independence or with kind of a cognitive behavioral model of anxiety in mind. So it's something that I'm really interested in. We have some pilot data that has shown the extent to which clinicians in cardiac rehab often do engage in some of these safety behaviors inadvertently. So it's something I'd love to look into more. So we've kind of skirted the issue by just training our own folks for now, but I do think that it really takes working together with the clinic in order to make sure that we're sending consistent messages to the patients. I think that's a real issue, if not directly targeted, could be an issue.
That's a great answer, and I think similar. Dr. Janine Simmons, who's one of our great champions of behavioral medicine at NIA, specifically in the context of the NIH stage model and the importance of considering fidelity issues early on. How are we thinking about maintaining fidelity of training these exercise physiologists when it's time? She says if and when. My guess is when it's time to scale this intervention up.
Yeah, I think that it's something I've been really interested in, kind of consistent with the translational work that I do, from kind of the lab to intervention development to then dissemination. I think there's a lot that I could do or others could do as a psychologist going into rehab. I think in some ways the logical next step, of course, would be to train our clinicians that are at rehab every day, on the floor with the patients. We did a study that we found that 95% of clinicians in cardiac cardiac rehab have not had any training in the assessment or treatment of anxiety, and they're interested in that. And so I think that there's a little we could do that could go a long way. But in terms of scaling up an intervention like this, I think it really would need some interdisciplinary kind of training initiatives that is really important and would be really exciting to do. I know that that's work that has to happen in due time, right? Consistent with our stage models, but it's something that I've been thinking through.
Well, Dr. Ferris, I have so many more questions and so many more things that I would love to talk to you about with this, and so many of my colleagues as well at CBCH who are sort of focused on different aspects of this issue. And so I imagine we'll be asking you to come and join us in a more limited setting. But I just want to say thank you from both the SOBC Resource and Coordinating Center and from the Roybal Center at Columbia for joining us, and let everybody know that this video will be available on the SOBC YouTube channel. It'll be on the SOBC website. I imagine we'll send it out around to the Roybal centers around the country as well. And Dr. Ferris, if people want to reach out to you to ask questions, how should they contact you?
Yeah, I'll put my email in the chat. And I would love and welcome anyone interested in chatting, collaborating. Happy to jump on yet another Zoom call and do it all again. So
we look
really
forward to it.
So thrilled to have been able to present, and I just wish I could have seen all of the attendees. But thanks again, and I'll love to keep the conversation going.
Absolutely. And also we hope to see everyone next week at the SOBC Capstone Conference, which will sum up the last 10 years of the SOBC program, the Common Fund supported program. SOBC is now transforming into something more sustainable over the years. And I'm sure you'll be involved in that, Dr. Ferris, as well. But thank you everyone for joining us, and see you soon.